Center. Today we're going to be chatting about transplants, both what's new and what we're already doing in transplant medicine and care. We're here with Dr. Malcolm McNamara, who is a transplant medicine surgeon. He focuses on kidney, liver, and pancreas transplants in both adults and children. Before we get started, I wanted to thank the Southwest Transplant Alliance and Donate Life Texas. They've been tremendous supporters and colleagues throughout this month, and I wanted to put a shout out to them. Don't forget to like the conversation as we're going along. You can do it multiple times, and also to share it with your friends. And be sure to leave any questions you have in the comments section, and we will get to as many questions as we can in our time. I know that Dr. McNamara may need to run if somebody calls, but we're going to go ahead and get started. So thank you for coming on.
Thank you for having
talking to us
and highlighting
absolutely
transplantation this month.
So tell us, Dr. McNamara, a little bit about what does a successful transplant require? What goes into that?
Really a successful transplant requires a huge team and very close interaction between everybody. That's the inpatient and the hospital side that we often talk about, and you hear me talk about, but really starts way back at the point where the patient gets referred at the right time, that they get through the process of needing an organ and get assessed so that we can understand what all of their needs are.
Okay. So it's more than just showing up and being, I have this organ, I'm going to put this in you.
Exactly. So
okay.
it's really a lengthy process that involves nephrologists, transplant surgeons, nursing, and many different team members for kidney and hepatologists and anesthesiologists, and all of us working together, essentially individualizing the care that person needs and preparing both for the operation and then for afterwards.
Okay. That makes sense. So when we're talking about transplantation, what organs and tissues can be donated? Can you donate anything nowadays, or are there still some limitations?
Well, the most common solid organ that is donated is the kidney.
Okay.
The other solid organs that frequently are used will be and donated are liver, heart, lung, and pancreas.
Okay.
Intestine is still a relatively small number of donors.
So you can donate, would that be I assume that would be parts of your intestine?
Well, this would be a deceased donor.
Okay.
There have in the past been some efforts for live donation of intestine, although that's very specialized centers. The majority would be a segment from a deceased individual.
Okay.
Usually in only very specific centers.
Okay.
Here at UT Southwestern, my focus is on the liver and the kidney donors, and then obviously we also have a very robust lung and heart program.
Right, and we're definitely going to talk about that. But you mentioned, there's you can make a living donation. I know we do that with kidney transplant here. What other organs can be done through a living donation?
So again, kidney by far and away are the most common. There are circumstances where people will also donate their liver, or not their liver in entirety, but a portion of it.
A portion of it.
And the liver is somewhat unique in that it can regrow. So when you take a segment away, the rest of it will expand to the same size as before.
I missed that in health class.
Yeah,
that's interesting.
It means that donation is possible. It's a very large undertaking when it's done. More commonly, where a parent will donate to a child.
Okay. Because it's smaller and then it'll work for them.
Because it can take away a smaller segment, and it's a little easier to do.
Okay.
But also, where an adult will donate to another adult as well.
Gotcha. Okay. Well, we have some questions coming in. So Georgia,
you're gonna stump me with
we have no. This is a pretty. So somebody's wondering, who can donate, and are there any health issues that would disqualify someone from becoming a donor?
So a living donor, it is going to be very carefully assessed.
Mm-hmm.
The goal of a living donation process is to do no harm to that donor.
Right.
So it starts as a very straightforward process of seeing whether they would be a potential match, or if they've got any significant disease that can be often worked out in a very simple questionnaire.
Okay.
If there's diabetes or hypertension, may often be something to rule out. What I tell everybody is, if someone comes forward as a potential donor, is to essentially let the professionals do the job, because things change a little bit. We're getting much better at making sure that more and more donors are safe. So we will generally, actually what we do now is we have an online system where people can log into it's called breeze.com.
Wow.
There's links, we provide links here, and a person can, from their own home, actually log in, and a lot of that information, early information, is gathered through that process, and then they've got an answer. Dr. Justin Perek is at the forefront of bringing that to UT Southwestern.
That's good to know.
So he's been piloting that, and that's really a nice way of allowing a living donor to explore things quickly, easily, and then if they're not a potential donor, at least they learn a lot about the process.
So that brings up another question. When somebody, they've been deemed, they're told that they can be a donor, and they're going to go through the process. What happens to those organs and tissues between transplantation? Before they're taken out, and then something happens, and then they're put in, right?
Yeah, essentially, I guess. You make my job seem very easy.
No, it's not. It's not.
No, I wish. So it actually, it's very, again, it's a big team approach. It's very well coordinated. So you're going to plan for the recipient of the organ to be present in the hospital.
Okay.
As long as we actually do some paired exchange as well. But for the straightforward, they're both going to be in the hospital, and the kidney is going to be first removed. We do that laparoscopically.
Okay.
Almost all cases here.
Wow.
The kidney is removed, and then usually we're in very close communication. The recipient and donor surgeon, so that as soon as the kid, as soon as they're progressing to a point, we start the recipient surgery, and then the kidney.
Yeah, because they're not always in the same hospital, right?
If they're in different hospitals, again, also requires close communication. We take part in paired exchange groups, which means, let's say, in every other way you're a match, but you're not the same blood group, or you're healthy, you could donate a kidney. Okay. You match it with someone in some other part of the country, or who is the mirror image opposite, and then your kidney is donated to their recipient, and their kidney is donated to your recipient. And that involves
a lot of coordination.
But it's really a very it's a wonderful thing when it comes to
I've heard stories of that happening, where sometimes there are two families involved, sometimes there are more than two, and one goes here and one goes there, and it's a miraculous.
It's pretty amazing. And then another amazing sort of chain of events can start where someone, as an altruistic donor, comes forward that doesn't have a specific determined person, but would like to donate, and that happens from time to time, and is an amazing thing to be part of and see the incredible benefit people get.
So it looks like we have another question. So Sunita is wondering, after a transplant is completed, what does it mean to have a sleepy kidney?
Sleepy kidney?
Yeah, I haven't heard that term. A sleepy kidney. What is that? Do you know?
So that's a term that we'll often use to describe the transplant when takes a little while for the function of the kidney to kick in.
Okay.
Like. And the process of removing it from one body, preserving it, and then hooking it to the blood vessels and getting blood flowing through it, it causes some temporary injury to the kidney that it overcomes before functioning.
Okay, so it takes a little bit longer to kind of
Correct. And it means that some people need dialysis for a short period of time after their transplant.
Okay.
In that case, for most living donor kidneys, that's not something we see. In fact, it's very rare. For the deceased donor kidneys, probably about 1 in 4 will have a sleepy kidney. But a month out, a year out, and moving forward, we expect that kidney to be working and working well.
So one of the things we talked about before we started this was we talked a little bit about the advancements that are happening in transplant care. And I was wondering if you could talk a little bit about that, like maybe perhaps the ex vivo machine. I know that's a new thing that we're still learning about.
And that's a really, really exciting part of what potentially could come in the future. So
maybe tell what the ex vivo machine is designed to do.
So to frame it, for the last 40 years or so, what happens when an organ is removed from the donor is that it goes into a cold solution, and it sits essentially on ice or at a cold temperature until it's ready. And what that does is it slows down the rate of metabolism so that it reduces the amount of injury. People have, from even 40 years ago, looked to a different option, and this is where we're re-exploring these options, where now, instead of cooling it down, you circulate fluid through it. In the lung system, they still keep it cool. We're actually getting ready to start a liver ex vivo, where we'll actually circulate blood that's at body temperature, that has oxygen, that has nutrients, that has antibiotics around the liver, and with the goal of first seeing how that liver functions outside, and that if it functions better and better, we know we have a good liver. But ultimately, the hope would be to make that liver better, so that it's going to function faster and better, and that the recipient benefits hugely from this process.
So with that in mind, is the thought also that maybe as you could take a liver at that point that maybe wasn't quite perfect and bump it up? I mean, I don't know how to say it medically. I sound very casual right now, but maybe improve it a little bit to make it better for the recipient? Is that
absolutely? I mean, I think that's the goal. Make average livers better, make good livers better, but also make the ones that are a little iffy, or that you kind of go, I gotta find, or that's not right for my patient. That you then would be able to assess it, make it better, and then be like, it is right for my patient. And one of the things I think that is going to be very exciting is can we change some of the fatty livers that we have?
Oh wow! That seems to be a growing part of the population.
It is, unfortunately, for all of us. But I think being able to work better with those by altering them outside the body, so that they're actually much more manageable when they're transplant, I think is very exciting. The lung team, and they'll talk in far greater detail than I can, but they're ahead in general. The lung teams and the lung cardiothoracic use of these ex vivo processes are working to recondition some of these livers. They've done some very exciting things where they've taken a liver that they would have otherwise, a lung, where they would have otherwise discarded, and made it possible for use.
It seems that would make donation even little maybe help with the numbers.
Exactly, and you know, I mean, we're talking about donation this month. You know, we have, you know, there's about probably 7,000 liver transplants done per year, but there are about 15 to 16,000 people on the wait list.
Wow.
And every year there's around 2,000 to 3,000 people who will not make it to liver transplant.
Wow.
So even a small incremental change in the number of organ donors could
help that.
Could massively work towards addressing that.
Well, I want to get back to that, but I want to thank again the
Sure.
Southwest Transplant Alliance
Yes.
for promoting this, and Donate Life Texas. And again, don't forget to continue asking your questions in the comments. We've got a couple more that have come through that we will get to. And again, don't forget also to like and to share the conversation. Now, Dr.
If I can just talk about Southwest Transplant Alliance
Absolutely.
and donation in general in Texas. The state in general is a very generous state for organ donation. The organ donation teams have increased the rates really spectacularly in the last number of years, and we're seeing that benefit in our patients, and they definitely are going to be hugely applauded for the hard work they do.
That's yes, we're very grateful for that partnership, and that actually brings up a point that somebody from the foundation or the Transplant Alliance, they put out a message about this chat on their pages, and from that we had one of our questions come through. That's from Sandra, and she says, I'm 26 years old. I'm at 26 years out from my liver transplant and very healthy. Will there ever be a time when I won't have to take medications? Is that a lifetime deal? I've heard different things about that.
So, in general, the answer is that, as it stands at the moment, that she will continue to take immunosuppression.
Okay.
And it is possible for the immune system to recognize the foreign tissue in the long term out. But generally, when you're a long way out, you have been able to reduce down the amount of immunosuppression. So maybe go from 3 drugs to 2 drugs to 1 drug to a drug at a low level. Because all the time we're trying to balance infection risk or side effects from medications.
Gotcha.
But she should be applauded for getting 26 years out. That's incredible.
That's awesome. Yeah. So we've got one from Tina. Tina is wondering, she says, is it true that with a liver donation that you can just use a portion to donate? I know we touched on that a little bit, but maybe if you could touch on it again for Tina.
So it is possible to donate part of the liver. It is a very complex surgery to do that, and we're very careful. Again, as we described with the kidneys, the first rule is do no harm. So we would have to make sure that everybody is very, very safe. At present, we are not generally doing. We're not doing living liver donors, although that's something that we're looking to do in the future.
Yeah.
But we have to do that in a very, very safe and planned process.
All right, so we've got another question here from Juana.
Lots of questions.
Yeah, is it possible to use that machine, I think the ex vivo machine, to replace transplants? I guess what I'm trying to say is, can you take out a bad liver and put it in that machine to make it better for the same person? That sounds a little tricky. That's probably not what it's intended for.
That's not what this machine
What it does? Okay.
When the liver is cirrhotic, which is most of the reasons why we're transplanting, that's architecturally gone beyond something that can be repaired easily. People have looked to try to bridge with other machines people that have acute failures and see if there's something that they can try to bridge.
Okay.
Again, future, a little bit
down the road, maybe.
A little bit down the road.
Okay.
But for these chronically damaged livers, it's a transplant. But the better we can make that transplant for them, the easier that surgery goes and the more successful it can be.
Sounds like you're on the right way there. So Christina, she said, oh, she must have been looking at your profile. I heard that you study ways to prevent organ rejection. What are you working on now?
What's
new?
What's new? Well, one of the, organ rejection, at least in kidney and liver,
that you focus on?
That I focus on. We've become very good at preventing or reversing the early rejections. And so organs do very, very well for the first year. We expect a living donor kidney to be present and working 99% of the time. Now, when we get to 10 years, there's a fall off as things move on, and between medications and between other reasons for the organs failing, that's a real area that we try to address.
Okay.
Where I trained at Emory University, Chris Larson and Tom Pearson were at the forefront of developing drugs that are going to help with that chronic graft loss and try to improve the function of the liver. And it's our intention to bring some of that research, some of those drugs. One in particular is a drug called belatacept, which is not a calcineurin inhibitor. That's the ones that we commonly use to prograph, the cyclosporin, and doesn't have the same toxicities associated with it. And it was very exciting to that group that last year they were able to show that at 7 years out from transplants, that there was now a very significant benefit to this drug over the standard approach in a randomized trial.
That's a pretty
very
significant...
difficult that they had to go a long way out to 7 years to find that difference. But that's, again, because we're doing very well at the start. We want more successes, like 26 years.
Yeah, 26
after the
years.
liver transplant. And that's the exciting phase. The other thing, on a more pragmatic approach, is that a lot of the underlying reasons for losing a kidney later can be either medication related or not access to medication. And it's ensuring that people continue to take their meds or get help if they're having problems taking their meds. And that's not really research, but that's good practice that we try to, there are research in it, but what we have to do is ensure that we support good practices in our patients.
Absolutely.
So that's really the big things that we're focused on here, but I think they're key too, because we don't want short-term success without long-term success. We really want both.
Yeah, it seems like, and somebody was talking about this before, that transplant recipients now are living longer than ever, partly in part to the care they receive both before and after the surgery. So are you seeing that among your patients here? That they're doing better, that they're getting back to their routines quicker?
It's phenomenal how, even in a short period of time from my early training, how much shorter the period of time we keep our patients in hospital. I think most of our patients are home within a week if they come in for their transplant from a liver transplant.
For a week?
A week.
Wow.
Most of our kidney transplants are home in maybe 3 days. So we've shifted a lot of. We've shifted rapidly to and that's improvement in the preoperative planning. That's improvement in our anesthesia team. That's improvement in our nursing. That's improvement in everything that we work towards to get people back into their normal lifestyle.
Wow. Well, I know a lot of people online, they talk about like post-transplant. Are there any ways that people, and this may not be applicable, that people that are friends with transplant patients or that are related to transplant patients, is there anything they need to do to support them? Does the transplant patient's life change dramatically in any way?
At the beginning, this is one of the things we'll look into is the support is key. You know, you're getting over a major surgery, you're getting used to your medications, you need to travel back and forth. So having a group of people that can help and support you is key to that process. As people get further on, they become much more independent again. The key person in this process is really our transplant coordinator, coordinators.
Okay.
And our patients are going to do great if they keep in touch with their transplant coordinator.
Gotcha.
If they're their best friend, and if they have them on speed dial if there's any problems.
That's good to know. So the transplant coordinator is the key.
Transplant coordinator and
handles everything.
Absolutely, they are tremendous, and they're devoted really to their job here. And we can pick up a problem before it becomes a big problem. We can fix it before it becomes a big problem.
So our obviously there are some medical conditions that are genetic that might predispose people to needing an organ donation at some point. I mean, are there any groups that we really need to work to increase organ donor numbers in? I mean,
for donation.
For donation, yeah. Are there any groups that maybe they're on the list longer because there just aren't suitable donors?
I think across the board we need to continue to work.
Right.
You know, pediatric transplants are always something that we wait sometimes because we know we want a very good organ that's going to last for a long time.
It's hard.
The system of sharing organs is
it's blind, isn't it? In some ways.
Well, it's different in different organs. So for the liver transplant, it's whoever's sickest, and there are some people who can be, and it's we as the whole transplant community have a system for sharing that tries to allocate the organs as best as they can to the sickest people. There are some people who can be quite sick but don't score as high, and those are individuals that we always have to keep trying to find solutions and ensure that there's fair that there's fair access to those transplants. Again, we're very fortunate that in Texas
we have a very loving community.
We have a lot. You know, we do better than many other parts of the country in terms of the donation rate. I think we're right up there now with some of the highest countries in Europe that people have looked upwards to for many years. So that is helping transplant more patients and transplant more, because again we're very often we're talking about like we want to transplant them on the liver list before they die, but people can be on a list for a long time with a very poor quality of life or with a lot of medical problems. The kidneys likewise. So the quicker we can give them a suitable organ, the better.
So I know we're running out of time, so if there are any more questions, please put them through now. But with Dr. McNamara, is there anything else that you want to make sure that those who are listening know about UT Southwestern, about our transplant program here?
I think we're a growing group, and we have we have a lot of very talented people. We have a lot of processes that we're developing to be able to treat some of the most complex. In the last 12 months, we've done transplants that have included heart and liver combined, and lung and kidney combined, and lung and liver combined. And these are complex surgeries done only at very few transplant centers. But I think we're also we're looking to, even with the more straightforward transplants, to make sure that we've got the highest level of care and the best outcomes. And I think we're rapidly improving these processes.
Well, I should tell you all before we get off that we did a National Doctors Day post earlier this year, and we asked people to share praise or good thoughts about their doctors, and by and large, the transplant team I believe had more comments than just about any other group here on campus. The others were spread around, so you definitely have a loyal
We have a loyal
following.
We have a loyal following. They must be good Facebook users as well. That's great.
They are. There are lots. So I think now we're gonna wrap up today. I think we're running out of time, but I want to thank everybody for tuning in. And you'll be able to watch this again once we end the broadcast. So come back and watch it again. Thank you, Dr. Montgomery, so much for being with us today and talking about it. Next month, we're going to be talking a lot about stroke, so stay tuned for announcements about those chats with our physicians. And have a great day.
Thank you very much.